saludo muy especial para todos, para Fundación Cardiolili Hospital Universitario y su alianza profunda por la vida con la Universidad ICESI. Es un privilegio poder extender a toda la comunidad académica una cordial invitación para asistir a la 16ª versión de nuestro ya conocido Congreso Cardiolili. Se trata de uno de los más importantes eventos académicos institucionales y un referente nacional e internacional en el ámbito de la cardiología. En esta ocasión, y como ya es costumbre, tendremos conferencistas nacionales e internacionales de talla mundial. Para nosotros, compartir la experiencia y el conocimiento de vanguardia en un área tan especializada de impacto académico resulta una excelente oportunidad en nuestra misión de formación profesional. Nuestro permanente empeño en educar al más alto nivel requiere iniciativas que, como Cardiolili, aporta de manera relevante al crecimiento formativo, personal y disciplinar de estudiantes a todo nivel. Los invito de nuevo a ser parte de nuestra nueva versión de Cardiolili, la cual promete ser, como en otras ocasiones, de altísimo valor académico y de gran impacto global. Saludos a todos y sean bienvenidos a la 16ª versión de Cardiolili.
Muy buenos días a todos. Desde la Dirección Médica de la Fundación Cardiolili Hospital Universitario, les damos la más cordial bienvenida a esta, la 16ª versión del Congreso Internacional de Cardiología. Para nosotros, como institución educativa, es de suma importancia transmitir a los profesionales de la salud los conocimientos que desde nuestros profesionales del ámbito nacional y el ámbito internacional pueden transmitirnos a todos nosotros. Esta es una oportunidad más que brinda el servicio de cardiología de la Fundación Cardiolili Hospital Universitario en el proceso de formación de los profesionales de la salud. De esta manera les damos la más cordial bienvenida y la apertura a este evento. Muchísimas gracias por su participación.
El mundo de hoy nos ha enseñado que es necesario estar preparados para el cambio. El cambio es movimiento, el movimiento es vida. La vida es la que nos empuja hacia la excelencia en salud al servicio de la comunidad. En el transcurso de 4 décadas, nos hemos consolidado como referente en la prestación de servicios de alta complejidad. Para alcanzar nuestras metas, sustentamos nuestro trabajo en 4 pilares: la excelencia en la atención, la docencia, la investigación e innovación y la responsabilidad social. Como institución hospitalaria, nuestra vocación primordial es satisfacer las necesidades de nuestros usuarios bajo un modelo de atención humanizado, centrado en el paciente. Para hacer más eficiente nuestro compromiso, apostamos por una estrategia que nos permita atender a cada familia, desde cualquier lugar. Por eso implementamos una ruta que nos conduce por el camino de la investigación y la innovación en el campo de la ciencia médica. No le tememos a los retos que nos plantean día a día en nuestra labor. Somos un hospital universitario, lo cual nos permite asegurar la continuidad de nuestra misión. Creemos en una formación académica humanizada, ética y científica, puesta al servicio de la comunidad. Estamos comprometidos con la responsabilidad social que tenemos con nuestro entorno inmediato. Por eso, desarrollamos diversos programas de atención para la población más vulnerable. Nuestra permanente búsqueda de la excelencia nos ha llevado a romper barreras en campos muy prometedores: la telemedicina y la atención a pacientes internacionales. Los tiempos cambian, El mundo se transforma. Estamos preparados para afrontar los nuevos retos. La innovación y la calidez humana hacen parte de nuestra existencia. Fundación Valle del Lili. Excelencia en salud, al servicio de la comunidad.
Bueno, Sebastián nació el 3 de septiembre de 2012 en la Fundación Valle del Lili. Pues yo esperaba un niño sano. Se suponía que iba a ser uno de los días más felices porque pues lo esperábamos con ansias. Desde que nació pues noté algo extraño. Cuando llega un médico acompañado de muchos más médicos y una gran máquina, empieza a examinar a Sebastián y me dice que el caso es muy grave.
Sebastián nació con una cardiopatía congénita compleja y desde que nació estuvo hospitalizado en la unidad de cuidados intensivos cardiovasculares de nuestra institución, donde requirió varias intervenciones quirúrgicas para poder mantener su vida. Si bien todas las enfermedades son difíciles, el corazón impone un reto muy grande tanto para la familia como para el cuerpo médico, como para todos los que tienen que ver con el desarrollo y la evolución del niño.
Ya me dicen que tienen que hacer 3 cirugías. Vienen más complicaciones porque eso no es solamente como el corazón, sino que entonces ya apareció una bacteria, se le paralizaron las cuerdas vocales, tuvo una aplicatura de diafragma.
La Fundación Valle del Lili cuenta con un equipo excepcional, tanto en el grupo quirúrgico de cardiología pediátrica y de UCI cardiovascular y anestesia, con todos los equipos y todos los elementos necesarios para permitir desde la vida neonatal dar apoyo en el manejo quirúrgico de estas cardiopatías, donde estamos no solamente los cardiólogos, están los cirujanos cardiovasculares, neumología, cirugía pediátrica, gastroenterología, nutrición y los servicios de apoyo diagnóstico como son cateterismo cardíaco y rayos X e imágenes.
La Fundación Valle del Lili tiene un equipo médico excelente, es un grupo muy amplio. Yo pienso que allá encontrás todo, como que la meta siempre es la misma, que Sebastián cada vez esté mejor.
Sebastián ha crecido en medio de las dificultades, se ha desarrollado, ha sido un niño bastante feliz y esperamos en el futuro poder seguir manteniendo la buena calidad de vida de Sebastián gracias al soporte de toda la institución.
Gracias a la Fundación Valle del Lili por siempre tener sus puertas abiertas, por siempre buscar los mejores métodos, nuevos tratamientos para los niños y especialmente para los niños enfermos del corazón.
estaba yo en mi trabajo y me empezó un dolor, caminaba una cuadra y me ahogaba, tenía que descansar. No tenía pues idea de que pudiera ser el corazón, una enfermedad del corazón. Cuando me dieron el diagnóstico pues de la insuficiencia cardíaca, duré un mes que no pude trabajar.
John llega remitido a la Fundación Valledilili básicamente por una enfermedad a nivel de las válvulas cardíacas que conlleva a que su corazón crónicamente presente un deterioro progresivo a pesar del manejo farmacológico y el uso de diferentes dispositivos para el manejo de falla cardíaca. Vimos una enfermedad que a pesar del correcto manejo no había respondido como uno quisiera y el curso de la misma iba a ser progresivo hasta mayor deterioro e inclusive la muerte. Y es ahí cuando el grupo de falla cardíaca, que es un grupo de médicos y especialistas en trabajo multidisciplinario, consideramos la opción de trasplante cardíaco.
La gran mayoría de los pacientes sometidos a trasplante cardíaco son pacientes que están en lo que llamamos enfermedad cardíaca terminal, donde los estudios han determinado que la supervivencia del paciente va a ser inferior a 1 año. Entonces son pacientes que si no se operan y ya están en un estado terminal del corazón, con corazones severamente dilatados y con muy poca contractibilidad, son pacientes candidatos para trasplante de corazón.
Ya empezamos después cada mes a aplicarme un medicamento que llama levocimendal. Al año ya estaba cada 8 días, prácticamente tenía que venir a colocarme el medicamento. Me tocó volver por urgencias y ya me tuve que quedar aquí en la clínica esperando a que saliera un donante para mí.
Ingresa como urgencia 0 y después de más o menos 90 días se logra llevar a trasplante cardíaco en forma exitosa, realizado en febrero de este año.
Mi calidad de vida ahorita es mucho mejor porque puedo ya volver a retomar los ejercicios, ya puedo dormir bien, puedo tomar líquidos normal, no tengo náuseas, que era uno de los síntomas que tenía con el corazón anterior.
Para que un programa de trasplante cardíaco pueda tener el éxito que ustedes ven con John, se requiere un apoyo importantísimo y es de las familias de los pacientes que donan órganos.
Cada familiar que acepta que en su dolor se convierta en la vida de varias personas, cada donante puede servir para salvar 5 o 6 vidas.
¿Revisas que tenga el audio bien? Cordial saludo. Hoy damos inicio a la segunda semana de actividades académicas de Cardiolili 2023, en esta edición número 16, y en este programa académico hemos dejado para el día de hoy, 1 de noviembre, la conferencia magistral. Hemos tenido la oportunidad en eventos previos de contar con la participación de expertos internacionales y este año no queríamos ser ajenos a esta realidad. Teniendo en cuenta la situación actual de la enfermedad cardiovascular a nivel mundial y el impacto que han tenido los nuevos avances en cuanto a la fisiopatología de la enfermedad cardiovascular y el manejo de la misma, estudios clínicos que se han posicionado como relevantes en el marco de la cardiología, tuvimos la fortuna, el honor y la gran favorabilidad de contar con la participación ahora del doctor Paul Ridker para que dicte esta conferencia magistral. El doctor Paul Ridker, la idea es un breve resumen antes de empezar con esta conferencia. Es catedrático de medicina Eugene Brownwell en Harvard Medical School y es el director del Centro de Prevención de Enfermedades Cardiovasculares del Brigham and Women's Hospital de Boston, Massachusetts. A lo largo de 30 años, el doctor Paul Ridker y los colaboradores aportaron la primera prueba de principio de la hipótesis de inflamación de la aterotrombosis en seres humanos. El doctor Ridker y su grupo aportaron la primera demostración de que el tratamiento con estatinas es a la vez hipolipemiante y antiinflamatorio. Trabajaron también en la primera prueba diagnóstica de inflamación vascular aprobada por la FDA, proteína C ultrasensible. Como ustedes ven, el trabajo en esta área de enfermedad cardiovascular, de inflamación, de aterotrombosis, lleva tiempo y ha permitido que él se posicione como un referente a nivel mundial. No contento con esto, es a la vez el que trabajó con su grupo en el primer tratamiento antiinflamatorio de eficacia aprobado en la enfermedad cardiovascular, canakinumab, e introdujo en la práctica clínica un concepto muy importante en lo que es enfermedad cardiovascular y aterotrombosis, el concepto de riesgo residual inflamatorio. En múltiples ocasiones, el trabajo del Dr. Ridker ha modificado las directrices clínicas para el diagnóstico, tratamiento y prevención de la enfermedad aterosclerótica, que es la causa más frecuente en todo el mundo, inclusive en Latinoamérica. Como consecuencia de este trabajo, no debemos olvidar que casi todas las grandes empresas farmacéuticas a nivel mundial están trabajando en el desarrollo de nuevos medicamentos antiinflamatorios dirigidos a modificar el curso de las enfermedades cardiovasculares, desde la aterosclerosis clínica o subclínica hasta la enfermedad coronaria y la falla cardíaca. El trabajo del Dr. Ridker, junto con su grupo de trabajo de laboratorio básico y translacional, ha contribuido a llevar a la práctica clínica la primera nueva diana contra la aterotrombosis en más de 40 años. Y eso no está relacionado ni con colesterol, ni con presión arterial, ni con la coagulación. Inflamación. Además, el Dr. Paul Ridker ha trabajado en múltiples ensayos clínicos y ha dirigido algunos de estos, tan importantes como el Prevent, el Júpiter, el Spire 1 y 2, el Cantos, Prominent y Zeus. Continuamente recibe grants de apoyo y de financiación del NIH y ha sido galardonado con múltiples títulos honoríficos y premios internacionales. El Dr. Ridker es además un científico distinguido de la American Heart Association y es miembro electo de la Academia Nacional de Ciencias de los Estados Unidos. Finalmente, yo no podía dejar pasar por alto la relevancia que tiene a nivel de publicaciones. Tiene un índice H para el año pasado de 261 y adicional a eso tiene más de 300.000 citas acumuladas. Se encuentra como uno de los 15 investigadores biomédicos más citados en cualquier parte del mundo. No creo que me deba extender más y creo que más que seguir destacando los méritos del doctor Ridker, es nuevamente agradecerle la colaboración que ha tenido para participar en este evento académico, permitir que le pongamos un escalón más en cuanto al nivel académico y permitir que ustedes puedan disfrutar y compartir esta conferencia que él nos tiene dirigida para nosotros. Empezamos con la conferencia y una vez terminemos esta conferencia tendremos un breve espacio de preguntas que podemos compartir con él. Bienvenidos.
Well, it's an absolute pleasure to be joining you at the International Cardiovascular Congress, Cardiolili 2023 in Cali. I wish I could be there with you in person. My name is Paul Ridker. I have the honor of serving as the Eugene Bromwell Professor of Medicine at the Harvard Medical School. I have many good friends in Colombia and across South America and Central America. So thank you for allowing me to be with you today. I'm going to be talking about a very important topic to us, a real change going on in our world, anti-inflammatory therapy for atherosclerotic disease as an adjunct to statin therapy. The time has come. I have a variety of conflicts related to this discussion, which are shown here. I want to begin with a very recent happening in the United States. Low-dose colchicine, or Lidoco, at a dose of 0.5 milligrams, has just been approved now 2 months ago as the very first anti-inflammatory drug explicitly approved by the U.S. Food and Drug Administration for use to treat cardiovascular disease. This is a landmark event in my field. The indication here is quite remarkable, so I'm going to read it to you. Lidoco, or colchicine, low-dose colchicine, is indicated to reduce the risk of myocardial infarction, stroke, coronary revascularization, and cardiovascular death in adult patients with established disease, secondary prevention, or in patients with multiple risk factors for cardiovascular disease, high-risk primary prevention. That's actually the same labeling indication in the United States as statin therapy. Well, that's quite remarkable. So this discussion is going to be how do we get there and what can we do for our patients? I'm going to begin with a concept that is well known to all of you, this idea of residual inflammatory risk. We wrote this editorial back in 2016 when we created this term residual inflammatory risk to express what was different about this issue than was residual cholesterol risk. So my clinic, like your clinic, is filled with patients who have known cardiovascular disease. Most have elevated levels of LDL cholesterol, and most have elevated levels of the inflammatory biomarker high sensitivity CRP. In my clinic, and I suspect in yours, they'll all receive statin therapy, a high intensity statin. And for many years, we've talked about residual cholesterol risk. On the left, the patient who, despite being on a high intensity statin, the LDL remains elevated. We might want to bring that down further with second lipid lowering drugs. But today I want to talk to you about residual inflammatory risk. The patient on the right, the LDL cholesterol is well controlled, but the C-reactive protein remains quite elevated. In 2016, we did not have an answer to this question, but today we know that lower is better, both for LDL lowering and for inflammation inhibition. So the challenge in this talk today is, has the time come to chart a new course in the secondary prevention of atherosclerotic cardiovascular disease, and specifically ask two questions. What is the relative importance of inflammation and cholesterol as determinants of residual cardiovascular risk after you've given your patient a statin? And what are the anticipated benefits of adjunctive lipid lowering and adjunctive inflammatory inhibition after you've given your patient a statin? Well, we recently addressed this in a paper in The Lancet published a few months ago now, where we asked in 3 major clinical trials, the Prominent trial, the Reduce trial, and the Strength trial, to try to pull our data together and say, in contemporary among 31,245 statin-treated patients, what predicts risk? The first thing you see here is that high sensitivity CRP in the top half was highly reproducible across 3 major contemporary clinical trials. And the bottom half, you see that LDL cholesterol was highly reproducible. So first of all, high sensitivity CRP gives you very good data on inflammatory risk. We saw, however, that in the Prominent trial, the Reduce trial, and the Strength trial, and therefore in the combined data on the right-hand side, that the high sensitivity CRP in black was a far more powerful predictor of future cardiovascular events, in this case cardiovascular death, than was LDL cholesterol. Now that does not mean LDL lowering is important. But what it does mean is that once a patient is on a statin, the unmet challenge is the inflammation part of this process. So we went one step further and we divided patients according to a CRP level, a hsCRP, above or below 2 milligrams per liter, and LDL cholesterol above or below 70 milligrams per liter. On the far right-hand side, you see that risk is highest if the CRP is elevated and the LDL is elevated. And on the far left, you see the risk is lowest if the CRP is low and the LDL is low. But in between is an enormous challenge for us because the risk was actually very high when the CRP was greater than 2 milligrams per liter and the LDL was low. But the risk was not so high when the LDL was greater than 70 and the CRP was low. So that tells us that we need to focus on targeting inflammation at least as much as we're currently targeting cholesterol. And then finally, this is the anticipated benefits in randomized placebo-controlled trials looking at drugs we commonly use to reduce risk after statin therapy. Ezetimibe, a 6% risk reduction, PCSK9 inhibitors, evolocumab, alirocumab, a 15% risk reduction. And then you see on the right-hand side, the 3 inflammation-lowering trials, our own CANTOS trial, a 17% risk reduction, and then the 2 colchicine trials, a 23 and a 32% risk reduction. Well, the inflammation trials are delivering, if anything, greater magnitude of risk reduction. The question is then, has the time come to think about anti-inflammatory therapy? So let me give you a brief history of the field. You see here photographs of Russell Ross, who has passed, and then my colleagues Garan Hansen and Peter Libby. They have written 3 different review articles in the New England Journal of Medicine over a 20-year period that are cited here, talking about both innate and adaptive immunity. And I think you know well that in the vascular biology community, there's a lot of background to discussion today. I'm going to be giving a very clinical talk about how to apply this in actual practice. So my research group in Boston has been very concerned for a long time about one fundamental question. Can targeted anti-cytokine therapy reduce cardiovascular event rates and prolong life? The patient with rheumatoid arthritis that you see here shares a great commonality with the patient with severe systemic atherosclerosis. And yet we don't yet know how to target that inflammation to reduce risk. The right-hand side of this slide is an outline I'll show you multiple times today of the canonical NLRP3 inflammasomal pathway, where interleukin 18 and interleukin 1 beta are activated. These have direct anti-inflammatory properties on the vascular endothelium. They also upregulate the central signaling cytokine interleukin 6, which is now a target for therapy, as I'll discuss in a few minutes. Both of these upregulate hepatic production of C-reactive protein, the high-sensitivity CRP test, which is our clinical biomarker of residual inflammatory risk. And I'll take you through the therapies we have that target this and that we probably should be thinking about using in clinical practice. A bit of other history. For my research group, this work starts in the mid-1990s. In 1997, we published this New England Journal of Medicine paper, which showed for the very first time that low-grade inflammation precedes by many years the onset of cardiovascular events. That was very important. That tells us that the inflammation is not a result of the ischemia. It's actually a causal risk factor, just like high blood pressure or just like high levels of LDL cholesterol. And in this initial study, it was done in a randomized trial of the anti-inflammatory drug aspirin. And as you see in the lower left, there was effect modification for an anti-inflammatory drug. So this one observation would drive our work for the next 30 years. We would publish a series of New England Journal of Medicine papers talking about the concepts that low-grade systemic inflammation predicts future cardiovascular events, at least as well as LDL cholesterol. You see that data on the right-hand side. And on the left, that a variety of inflammatory biomarkers, not just hsCRP, but also serum amyloid A, which is an alternative contraxin, as well as interleukin 6, which I'm going to come back to again and again, as well as adhesion molecules, all teaching us a great deal about this disease. And we showed in the late 1990s that statin therapy, our fundamental drug to treat and reduce cardiovascular risk, is not only lipid lowering, but also anti-inflammatory. And these data are now well known to you that when we give a statin, we also lower C-reactive protein and that the greatest benefit of being on a statin accrues among individuals who not only have elevated LDL, but also have elevated C-reactive protein. In 1999, the actual clinical test for high sensitivity CRP was released for clinical use. It is of interest to me that today we still use the levels of less than 1 to 3, and greater than 3 milligrams per liter to define lower, average, and high inflammatory risk. We define residual inflammatory risk as a patient who is taking a statin who has an hs-CRP greater than 2 milligrams per liter. And this is the basis for all of our work moving forward. Many of you will recall that early on we also showed in the Prove It trial, and my colleague Aaron Bahula a decade later would confirm this in the Improve It trial, that when patients are treated with lipid-lowering therapies, they do best when the LDL is lowered and when the CRP is lowered, not simply when the LDL is lowered. And so this is this idea about trying to achieve low levels of inflammation as well as low levels of LDL cholesterol. And finally, in 2008, we published results of our Jupiter trial. We had very broad representation of South and Central America in the trial, so I'm sure there are some Jupiter investigators in the audience today. I want to thank them again. This clinical trial was not a fundamental test of the inflammation hypothesis of atherosclerosis because we used a powerful statin, rosuvastatin. However, this was a clinical trial designed for patients who would never receive a statin because it was primary prevention and the LDL cholesterol levels were already low. So low they would not receive a statin. But C-reactive protein levels were elevated above 2, and we had remarkable benefit, a 44% reduction in myocardial infarction, stroke, cardiovascular death, a 50% reduction in revascularization. And this is the only primary prevention trial to ever demonstrate a 20% reduction in all-cause mortality. And as you see on the right-hand side, if the only risk factor was an hs-CRP greater than 2, they got large benefit. So back in 2008, we knew that we should be giving statin therapy to a much broader group of patients. Then, with again a patient across the world and very good participation in South and Central America, we conducted our CANTOS trial. This was a trial of truly targeted anti-inflammatory therapy using a drug, a monoclonal antibody called canakinumab, which is a monoclonal antibody that targets interleukin-1 beta without doing anything else. We gave over 10,000 patients in 39 countries this drug against placebo. And we saw that you see in the lower left, dose-dependent reductions in C-reactive protein, dose-dependent reductions in interleukin-6, but crucially, no change in LDL, no change in HDL, no change in ApoB, no change in blood pressure, triglycerides, and yet we got the same 15 to 17% reduction in MACE or MACE plus that was observed in the PCSK9 trials. But remember, this was in the absence of any change in LDL or ApoB, simply by attacking the central canonical pathway of low-grade inflammation. So CANTOS is the proof of principle that we can indeed target inflammation to lower cardiovascular risk. However, canakinumab is not available for use from a cardiologist's perspective. First of all, it's a very expensive drug. And secondly, it's been repurposed for oncologic reasons. But today, with that knowledge behind us that if we target inflammation, we can benefit our patients, I'm going to talk about 2 further drugs. The first is low-dose colchicine, and the second is going to be interleukin-6 inhibition with a drug called ziltivekimab. Colchicine is where I'm going to start because colchicine is a very interesting drug. It's very inexpensive. It's a microtubule polymerization inhibitor, and it does have impact upon this pathway. Now, those of you following the literature are well aware that colchicine has a number of effects that are diverse, both in terms of inhibiting platelet activation. It is a drug that has profound effects on neutrophil function in a very positive way. And as suggested, it may interfere with inflammasome structure and lower CRP that way. We definitely know the drug lowers CRP. As a general cardiologist, prior to the new data coming out, I had used colchicine occasionally to treat pericarditis or to treat gout, but those are at much higher doses. We're talking here low-dose colchicine, 0.5 milligrams once a day, not 4 or 5 times that as you would use to treat acute gout. So what are the data? They come from 2 major randomized double-blind placebo-controlled trials. The first from Mark Neidorf and his colleagues called Low-DOCO 2, or the low-dose colchicine 2 trial. This was 5,522 patients with prior atherosclerotic disease, stable coronary disease, or high-risk primary prevention patients. They all were on statin therapy, and the great majority were on high-intensity statin. And the baseline CRP levels, even though they weren't part of the enrollment criterion, were roughly between 3 and 4 milligrams per liter. And they got a very large 31% reduction in risk. Now, remember, we get pretty excited these days to have a 10 or 15% relative risk reduction. It's a 31% reduction on top of statin therapy, very highly significant and a very clear-cut benefit. And there were really no side effects whatsoever. As you can see here, the rates of cancer, infection, pneumonia, gastrointestinal effects, and neutropenia were identical in the 2 groups. There was no evidence of myotoxicity when this drug was added to statin therapy. And if anything, there was less gout because colchicine is obviously an effective drug for gout. What's also very interesting is this landmark analysis that's been published from the Low-DOCO 2 trial telling us that at any point in the disease process, 1 year, 2 years, 3 years, or 4 years after the qualifying myocardial infarction, the patients just did better to be on this drug. Very similar to statin therapy, and this is as an adjunct to statin therapy. So I think many patients should be considered for treatment with low-dose colchicine. And we have a second trial, the COLCOT study that Professor Tardif and his colleagues were responsible for. COLCOT is taking patients who are in the stable phase past a recent myocardial infarction. They're on average 15 to 30 days out from a recent myocardial infarction. So this is not acute ischemia study. It's a recent infarct, stable infarct study. And again, they get a 23% reduction in risk. Again, 99% on statin therapy. While there was a small increase in pneumonia, that's not surprising, but the rates are very low, 0.9% versus 0.4%, but it is statistically significant. Meta-analyses have now been published that show a 25% reduction in hard 3-point MACE of myocardial infarction, stroke, or cardiovascular death, and a 60.67 hazard ratio, or 33% reduction if we add in coronary revascularization. Again, these are very large benefits compared to adjunctive lipid-lowering drugs, as you're well aware. There has been some controversy about these data because there has not been any effect on all-cause mortality, but that's not surprising. Most of our major clinical trials today do not have reductions in all-cause mortality. There has been some concern about potential increases in non-cardiovascular mortality, but again, in recent analyses, there's no cause-specific effect that's been shown at all. And remember, patients with familial Mediterranean fever take colchicine for 20, 30 years and have not had any long-term problems. However, if you're thinking about using low-dose colchicine, there's 2 or 3 things you need to be aware of. First, this drug is not for everyone. I would not prescribe low-dose colchicine to patients with severely impaired kidney function or hepatic function. The drug is metabolized by both the liver and the kidney, and this would be a problem. And one has to be aware to discontinue low-dose colchicine at least for a week or so if there's concomitant use of moderate to strong CYP3A4 or P-glycoprotein inhibitors. In usual practice, these are pretty rare drugs. It's clarithromycin, ketoconazole, fluconazole, and that's really about it. But it's worth knowing that if you're going to start these drugs, or if a referring physician starts these drugs, the patient should probably discontinue their colchicine for just a week or 2 to be safe. You have in South America the 0.5 milligram dose, which is the appropriate dose to give, so I won't review why this is a better dose than the 0.6 gram dose. I show this simply because in the United States, we're now getting a 0.5 milligram dose that we can use here. What's exciting is that low-dose colchicine has entered all major guidelines in the Americas and in Europe. It entered the European guidelines back in 2021. It entered your South American, Central American guidelines last year, and just a few months ago, it entered the ACC/AHA traditional guidelines here in North America. So now we have clarity that yes, for the first time, anti-inflammatory therapy is not only available, but highly effective. I want to change now to a discussion about interleukin-6 inhibition. Because yes, you can give colchicine today, and I do recommend you think about colchicine for your patients. But we're now embarking on a series of new clinical trials that are targeting the downstream mediator that we think is responsible. Remember in the CANTOS trial, we gave canakinumab, an interleukin-1 beta inhibitor. One of the major effects of giving an IL-1 beta inhibitor is to block the production of interleukin-6, the central signaling cytokine. And what you see here were pre-specified analyses of the CANTOS trial telling us that on the right-hand side, for example, when the patient receiving the IL-1 inhibitor had a greater than median reduction in interleukin-6, they did extremely well, a 36% reduction in cardiovascular events. But if another patient received that drug and did not get a greater than median reduction, there was really little benefit. So we think that the major way to go here is to target IL-6 potentially directly. Well, what's the data to support that? On the left-hand side, you see a paper that we published 23 years ago, trying to argue that interleukin-6 was a major risk factor for cardiovascular disease. And on the right-hand side, you see a meta-analysis that is now 10 years old, showing all of the subsequent epidemiologic studies. So clearly, IL-6 is a powerful predictor of future cardiovascular events. What you may not be aware of is that there has been animal data for some time, telling us that we have drugs that are typically used for rheumatoid arthritis or for Crohn's disease or inflammatory bowel disease that block interleukin-6 signaling. And as you can see on the right-hand side, at least in a mouse model, when a murine anti-IL-6 inhibitor is given, we see less evidence of atherosclerosis. So my colleagues and I, working with a drug called ziltivekimab, this is a fully human monoclonal antibody that targets the interleukin-6 ligand. This drug was developed specifically to be tested in atherosclerosis. And in late 2021, we published the phase 2 data shown here telling us that this drug, which targets IL-6, has a 85 to 90% reduction in high sensitivity CRP. That's really important because in CANTOS, we only lowered hsCRP by about 40 to 45%. So by targeting IL-6 directly, we're getting much greater reductions in hsCRP, and perhaps we'll see greater reductions in inflammation itself and greater reductions in cardiovascular events. What you see on the right-hand side of this slide are waterfall plots showing you that compared to placebo in black, where half the patients go up and half the patients go down, when you give active therapy in red, 7.5 milligrams, in blue, 15 milligrams, or in green, 30 milligrams, almost everybody responds with an 85 to 90% reduction in their hsCRP. So we think this is a more potent direction to get there. And I'm very pleased to let you know that on the basis of those data and other evolving data, Novo Nordisk in Copenhagen has launched 3 global trials, including many, many sites across South and Central America, that are asking the question, will interleukin-6 inhibition with this novel drug, ziltivekimab, improve cardiovascular outcomes? And there's 3 clinical trials going on. The first, which I'm the co-chair of, is called ZEUS. ZEUS is ziltivekimab in patients with chronic stable atherosclerotic disease who also have chronic stage 3 or stage 4 kidney disease, and they have residual inflammatory risk. That is to say, a high sensitivity CRP greater than 2 despite statin therapy. We're focusing here on chronic kidney disease because these are patients who you cannot give colchicine to. As I said before, you don't want to give colchicine to patients who have severe renal dysfunction or kidney disease or hepatic disease. And this is a secondary prevention study where the residual risk is very, very high and we think we can target this with interleukin-6. We're actually 65% enrolled globally, so if you are a Zeus investigator, please try to get the remaining patients in by December or January of this year. The second clinical trial going on is called Hermes, which has just begun. This is addressing whether or not interleukin-6 inhibition will be effective in the setting of heart failure with preserved ejection fraction. For reasons of time today, I'm not going to take you through the biology of that, but as you're well aware, heart failure with preserved ejection fraction has few therapeutic options, and there's a great deal of interest in inflammation as a mediator of heart failure in that setting. And finally, the third major trial is called Artemis. Again, this is now looking at acute myocardial infarction, acute coronary ischemia, giving interleukin-6 inhibition immediately. And this trial is just beginning. So if you are a major acute coronary ischemia site and are interested in participating in this trial, feel free to send me an email and we can contact you about potential participation. I want to end this talk, however, with some very clinical look at this data. What you see on the slide are a group of orange diamonds and a group of red diamonds. The orange diamonds is the traditional view on the x-axis, the percent reduction in LDL cholesterol, tracking with the relative risk reduction in cardiovascular events. All of the statin trials in both primary and secondary prevention generally fall on that line. But the red diamonds on the left, those are the results of the CANTOS, the COLCOT, and the LIDOCO-2 trial, the 3 anti-inflammatory drug trials we have completed to date. And in each case, we're seeing large relative risk reductions, large absolute risk reductions with no change in LDL cholesterol or ApoB whatsoever. So the first lesson is the time has come to think about inhibiting inflammation. And the second level is this is not a substitute for lipid lowering. It's something that we do on top of aggressive lipid lowering. The second thing I want to tell you is that residual inflammatory risk turns out actually to be very common. If you're not measuring high sensitivity CRP in your patients, I think you should. You will discover that for every 1 patient with residual cholesterol risk, there's approximately 2 to 3 patients who have residual inflammatory risk. That's important. It's telling us that we as physicians need to measure inflammation the same way we measure LDL cholesterol, the same way we measure blood pressure. We can't just guess who's going to have a high level of CRP. You need to actually measure. The test has been available for many years, and it's very informative about who we want to target anti-inflammatory therapy to as compared to who we might want to target aggressive lipid-lowering therapy to. I am a preventive cardiologist. I also want to point out that diet, exercise, and smoking cessation are all anti-inflammatory. The right-hand side of this slide is the preferred food pyramid for the United States. You notice that there is exercise equipment at the bottom and healthy foods, fish, whole grains, and fruits, and the use of olive oil, and at the very top, red meat, much less red meat. I know that in certain parts of South and Central America, that's not a dietary recommendation that's lightly taken, but this is the way to get there from a preventive point of view. It's also worth knowing that the famous Predimed clinical trial, where patients on a background Mediterranean diet in Spain were randomly allocated to receive either extra servings of nuts or extra virgin olive oil. Both of these interventions lower inflammatory milieu, and they both lowered events. And as was said by Annette Christ and Ika Lotz back in 2019, the Western diet appears to be mistakenly recognized by the immune system as a threat to the organism. And in closing, I want to remind you that all autoimmune diseases are associated with increased cardiovascular risk. That's another important concept, because the idea that's being put forth today is that inflammation from any cause is problematic for atherosclerotic events, and it's problematic for the development of disease in our patients. So in patients without an autoimmune disease, we already know that elevated levels of C-reactive protein, the higher the level of the CRP, the higher the level of the risk for myocardial infarction, for stroke, for cardiovascular death. But what this data from the Lancet coming out of the UK Biobank tell us is that for many different autoinflammatory diseases, and these range here from rheumatoid arthritis to Sjogren's syndrome to vasculitis to Addison's disease to multiple sclerosis to psoriasis, etc. In each case, you're seeing an increased risk of premature atherosclerotic disease. That's a very key concept. It's telling us that this pro-inflammatory process is being experienced by the vascular endothelium as a toxic insult, and it's telling us that in each of these cases, as in the general population, we can expect that if we lower inflammation, we probably can improve outcomes for our patients. And finally, I want to be very clear. I'm an aggressive lipidologist. I'm an aggressive preventive cardiologist. I absolutely believe in lipid lowering and in LDL lowering as far as we can go. It is not an either-or situation. Lipid lowering and inflammation inhibition are not in conflict with each other. These are synergistic therapies. I strongly believe that in the future, the combined use of aggressive LDL lowering and inflammation inhibiting therapies may well become standard of care for almost all of our atherosclerotic patients. And today, you can do that using inexpensive low-dose colchicine as long as the patient does not have severe kidney disease or severe liver disease. But this is not a substitute for being aggressive about lipid lowering. It's a synergistic additive treatment. Further, in addition to increasing the use of targeted anti-inflammatory therapies for atherosclerosis, evidence regarding residual inflammatory risk and residual cholesterol risk strongly support all society guidelines about efforts directed at primordial prevention. Because remember, dietary discretion, weight loss, exercise, and smoking all lower vascular event rates, and they all lower systemic vascular inflammation. We're also seeing the results of new drugs coming along. I just show you here the data for bempedoic acid, which you know was given to statin intolerant patients and had a modest 13% reduction in risk. But the important issue is on the right-hand side. This drug both lowered cholesterol by about 20%, and it lowered high sensitivity CRP by about 20%. And this is evolving as a new strategy of giving drugs that both lower LDL and hsCRP. And most of you are following the GLP-1 receptor antagonist story, and you're well aware that when you give these GLP-1 drugs, yes, the patient has lower vascular event rates. Yes, the patient has improved cardiovascular outcomes. Yes, the patient loses weight, but also the level of C-reactive protein is coming down, which again, I think makes sense in terms of why these drugs are effective. And finally, this is my last slide. For those of you interested in low-dose colchicine, along with Kyle Nelson and Valentin Fuster, we just published in JACC a few weeks ago, a major review article going over the clinical presentation of patients who we are interested in treating residual inflammatory risk as well as residual cardiovascular risk. The assumption here is that this is chronic secondary prevention, stable atherosclerotic disease. Patients who are previously treated with a high-intensity statin. You measure the LDL cholesterol, you measure the high-sensitivity CRP, and depending on which one of these is elevated, you might choose to treat residual cholesterol risk, you might choose to treat residual inflammatory risk, or you might choose to treat both. But the point here is the time has come to shift beyond simply lipid lowering, but also to go ahead and inhibit inflammation as a new way to lower cardiovascular event rates. I again want to thank you for the time today. I wish I could be in Cali with you. I look forward to seeing many of you face-to-face at the major European and major North American meetings. And I hope that we can travel sometime to see you at home. But again, I want to thank the organizers for the opportunity to speak to you today, and I'll be happy to take question and answers in the live session to follow this talk. Thank you. Enjoy the rest of your meeting. It's been a tremendous honor for me to be able to speak with you today.
Bueno, ahí estamos con audio. Marín, las preguntas. Hello, Dr. Ricker. How are you?
I'm very well. Good evening, Juan. It's very kind of you to have me with you. It's an honor to be talking with your audience today.
With the honor, as we mentioned at the very beginning, is for us having you here. It's real astonishing to have you here and learn more about prevention of cardiovascular disease.
y ver toda la
And
prevención de las
at this
enfermedades
point, we
cardiovasculares.
want
Y en este
to
momento,
let the
nosotros
people know that we
quisiéramos
have
compartirle a la
opened the
gente y
field for
saber que tenemos el
questions. If
campo
you have any
abierto
question
para
here,
preguntas. Si tienen
uh,
alguna
first of
pregunta,
all,
aquí,
I mean,
primero que todo,
you showed us
usted
a,
nos mostró
a big view about
una
cardiovascular prevention or
general
secondary
de cómo
prevention.
la
Is
prevención
there
primaria,
any
la
role
prevención
for
secundaria.
primary
¿Hay algún rol
prevention?
para prevención primaria?
With inflammation, you mean?
Con la inflamación, ¿quiere usted decir?
Yes.
Inflammation,
So,
I mean about the role of
Con la inflamación,
anti-inflammation
el rol
and
de
taking these
antiinflamación
treatments.
y
yes.
al tomar
So,
estos
if you
tratamientos.
think about it,
Si
our
ustedes
Jupiter
piensan en
trial,
esto, en
which
nuestro ensayo Júpiter,
we had
el
people in
cual nosotros
Colombia working with
tenemos
us. The
gente en
Jupiter
Colombia que
trial
está
was a
trabajando con
primary
esto,
prevention
él
trial,
es
which
preventivo,
focused on patients
principalmente
with
se enfoca en
elevated high
pacientes
sensitivity
con alta
CRP who did
sensibilidad
not have
CRP,
elevated levels of
no tienen
LDL
niveles elevados
cholesterol.
de colesterol
So in many
LDL.
ways, that was the
Así que
first
en muchas
anti-inflammatory
ocasiones es
clinical
un
trial, and it was
antiinflamatorio, un
very
ensayo
successful.
antiinflamatorio que
We've
ha sido
also
muy
learned
exitoso.
that
Nosotros hemos
screening
aprendido
for
también que
high
en
sensitivity
las imágenes de
C-reactive
alta
protein is
sensibilidad,
very
la proteína
effective
reactiva
at
C
identifying high risk in
y al
primary prevention.
identificar el riesgo alto en
Um,
la prevención primaria.
but as of today,
Pero al
even though
día
the
de
FDA
hoy, dado
approval for
que la
colchicine included
aprobación
high risk primary
del
prevention,
Departamento de
I'm
Alimentos y
feeling like maybe
Medicamentos,
we
yo
should get
siento que
comfortable
nosotros
first
debemos
with
estar
high risk
cómodos
secondary
primero
prevention.
con la
But all
prevención
the
de alto riesgo
biology is the
secundario.
same.
Toda la biología es
The
lo mismo.
future of statins
El
has
futuro de
changed with
estatinas
those
ha
new
cambiado
medicines.
con esos nuevos medicamentos.
I'm sorry, can you repeat that?
¿Podría
I mean,
repetir?
I'm talking about the
Estoy
relevance
hablando
of
de la
statins.
importancia de
Do
las
you think that
estatinas.
with new
¿Usted piensa que con
anti-inflammatory
los nuevos
medicines, the
medicamentos
big role of
antiinflamatorios, el
statins
gran
have
rol de las
changed or is going to
estatinas
change?
ha cambiado
Ah,
o va a cambiar?
I hope the audience
Yo espero
understands
que la
that
audiencia
everything
entienda, comprenda que
excuse me, everything I'm talking about
todo lo que yo
is
estoy
really on
hablando
top
está
of statin therapy.
relacionado con
I think statin
la
therapy will be here
terapia de
forever as
estatina
our
alta.
baseline
Es como la
first
línea base
pharmacologic
primero.
intervention in both secondary and primary prevention. What I'm talking about is treatment on top of statin therapy. So no, I don't want people to discontinue their statins. I think they're highly effective and very safe and very effective.
Dr. Juan Camilo Alvarez is asking, low dose colchicine post myocardial infarction for how long?
Well, the trials suggest that you take it for the rest of your life. It's just like being on a statin. And remember, it's safe. Patients with familial Mediterranean fever take low-dose colchicine for 20, 30 years. There's no increased risk of cancer. There's no increased risk of major infection. What we're learning about anti-inflammatory therapy is it's a chronic treatment to slow the progression of atherosclerotic disease, very much like statin therapy. The same way we take lipid lowering for the rest of our lives if we have high risk, I think that will also be the case for anti-inflammatory therapies.
Do you think, or do you have in mind, or are you working in a polypill including colchicine?
That's a very, very good question, Juan. The answer is yes. I think I have spoken with a manufacturer of the low-dose colchicine that's been released in the United States, and I have encouraged them. I think that we have a big polypharmacy problem, too many pills. And I think a secondary prevention pill that had, say, atorvastatin at 40 milligrams, aspirin, 125 milligrams, and 0.5 milligrams of colchicine, that would be a very useful drug to have. So yes, I hope they go in that direction.
Excellent. The other point is any new different anti-inflammatory medicines you've been planning in the future, or can we look for different anticlonal or different type of medicines for the future?
Well, I talked a bit about the ongoing trials of the interleukin-6 monoclonal antibody ziltivekimab. That's the ZEUS trial, the Hermes trial in heart failure, and the Artemis trial in acute coronary ischemia. But there are other anti-inflammatory targets that are not in the canonical NLRP3 to IL-1 to IL-6 pathway, and we'll have to see whether they work. The other thing you're going to hear at the American Heart Association meeting in just a few weeks, we've all heard that the SELECT trial with semaglutide, the GLP-1, has worked to lower cardiovascular events. That was the top line data. We'll see the actual data at that meeting. And of course, that's a drug that's, like all GLP-1s, very effective at lowering obesity, but also at lowering high sensitivity CRP. So I think the idea that lower is better for CRP, just like it is for LDL cholesterol, is going to become very much a mainstream topic for us.
Jose Roberto Vélez makes a point about the successfully regression of atherosclerotic plaque that we've been doing with different medications. Is there any advance in the infectious field with Helicobacter pylori, cytomegalovirus, and stuff like that?
Well, many different infectious disorders do lead to a chronic inflammatory state, but trials of purely infectious agents have not been effective to date. But I think we've learned from COVID and a lot of other disorders that have chronic infectious states that risk is high. So again, from a preventive cardiologist perspective, I would treat these patients as high risk and be aggressive with them, just as if they had hyperlipidemia or hypertension.
Mario Fernando Enriquez asks if is there any trial going on about prevention of secondary events in revascularized patients?
In revascularized patients?
Yes.
Well, those patients are eligible for the ZEUS trial and for the Artemis trial, which is starting next year. They're not specific to patients who've had coronary artery bypass surgery or specific to patients who've had angioplasty, but those patients are indeed eligible. There are some smaller trials, very interesting mechanistic trials, asking questions about what would happen if we dampen the inflammatory response immediately at the time of acute coronary ischemia as we are doing the primary angioplasty. These are mechanistic trials looking at surrogate endpoints like infarct size, change in FFR, and things like that. It's all very exciting.
Neiro Jesus Delgado mentions, I think something you consider is like obesity, diabetes, high blood pressures need to be well treated before considering colchicine and modify the inflammatory subset. I know that modifying those risk factors is always the pillar of cardiovascular treatment. Don't you think that?
I fully agree. And let's be very clear. Dietary discretion, exercise, smoking cessation, weight loss, these are always going to be the bedrock of cardiovascular prevention. In all of the clinical trials that my group does, all the patients get recommendations for that in both the active and the placebo group. And you're absolutely correct that all those should be initiated at the beginning. We know, however, that people who don't smoke, who have lost weight and exercise still have atherosclerotic events. Hopefully they have them later in life, but we still want to be aggressive if they have certain risk factors, such as an LDL, such as a CRP.
Tania Maria Bosque asks, I think in general, is there any specific time frame to take statins and anti-inflammatory medicine?
I think right now, the best data is for patients with chronic stable atherosclerosis, and we can just initiate the therapy at any point in the disease process. Whether or not this will be effective in acute coronary ischemia, we really don't know yet. So right now, I'm using this treatment in patients of mine who have chronic atherosclerosis, but that's a lot of patients.
This is a frequent question, and we deal with that with the patients. My LDL now is 15. How low should we pursue? I know, but this is must-do question. How low the LDL?
Well, all the data we have suggests that lower is better. But I think once you're below the guideline directed levels, you're fine, because the incremental cost, the financial cost of every additional milligram per deciliter reduction in LDL beyond a high intensity statin, it gets very expensive. So a reasonable approach might be to say, well, have a patient with familial hyperlipidemia or homozygous FH. Yes, these patients should be very aggressively lowered. But I think in general practice, getting the LDL down with a high intensity statin, maybe one adds ezetimibe on top of that. But once you're talking about giving a PCSK9 inhibitor or inclisiran, yes, they work, but in certain environments, including here in the United States, it becomes very, very expensive. But from a safety perspective, as far as we can tell, there's no, low is just fine.
If we have a low LDL, shall we try to modify to reduce treatment medications, just keeping the low LDL, trying to avoid medications, and as you mentioned, low cost, trying to reduce doses or number of medications? Shall we try to do that? Or just if I reach it a low LDL, just keep on that and keep going that?
Well, let me repeat a couple of things we talked about. PCSK9 inhibitors are very effective at lowering LDL cholesterol, but they don't lower this inflammatory response. So even if you had someone on a statin and ezetimibe and a PCSK9 inhibitor, but their CRP is high, you might actually consider them for anti-inflammatory therapy anyway. I am well aware that patients are reluctant to take a large number of drugs. You asked very importantly about the poly pill. I completely agree. I also think many of our patients have diabetes. Many have other issues. They have other disorders. And so I, as a physician, spend a lot of time describing the drugs I think patients should really take. And then perhaps we can discontinue some other medications that are less important. But that's an individualized discussion with each individual patient.
Dr. Gustavo Montero asks, is there any different type of risk if I have atherosclerotic disease in the brain, in the coronary artery, in the aorta?
Well, I think the disease itself is quite similar, but obviously the clinical manifestations are extremely different. The bigger question is, I think, large vessel peripheral arterial disease. So carotid disease, coronary disease seems to act quite similarly, but we have not developed very good therapies for lower extremity large vessel peripheral arterial disease, and we need to do that. But we worry about atherosclerosis as a systemic disease.
Have you seen in the different trials? It asks by Jose Guadalupe Barrera. Have you seen in the different trials in rheumatological patients less? I'm talking about the anti-inflammatory medication and colchicine. Have you seen in rheumatological patients less incidence of cardiovascular complications?
So patients with a variety of autoinflammatory disorders like rheumatoid arthritis have increased cardiovascular risk. There has been observational data that when we treat these patients with aggressive anti-inflammatory therapy, their rates seem to come down, but these are not randomized trial data. So I think we should stick with the randomized trial data for now. Juan, I'm going to have to apologize. I have some things I have to do here at home, but I want to thank you enormously for the opportunity to speak to your colleagues in Colombia.
I have two final comments. I'm going to take note about having you here in Colombia. The other point is asking you to reconsider including Colombia in Artemis. I know you selected different countries, and hopefully in the future you can consider Artemis. And finally, I want to thank you again for letting us having you here. It's an honor having you in our Congress, having you sharing these big concepts. And thank you very much, Dr. Ridker.
The pleasure is entirely mine. It's great, and I do hope to see you in person very soon. Thank you.
Thank you very much. See you later. Bye-bye. Aprovecho para agradecerle a los casi 600 asistentes que tenemos hasta ahora. La idea es que esta conferencia vamos a trabajar para que, junto con las actividades virtuales que tuvimos la semana pasada, puedan estar en la plataforma de YouTube de la institución y ustedes puedan compartir esta excelente conferencia que acabamos de escuchar. Agradecerle a todos los asistentes, a todos y cada uno de ustedes quienes participaron en la parte de preguntas. Esperamos que las respuestas hayan sido, hayan resuelto sus dudas y los invitamos mañana en forma presencial a quienes están en la región, nos puedan acompañar ya en la parte presencial. Les recuerdo que la actividad virtual va a estar disponible online a partir de la próxima semana por un periodo más o menos de un mes, un poco más de un mes. Cumplimos con el horario, teniendo en cuenta la actividad del doctor Ridker y que tenía una urgencia, nos quedaron realmente 3 minuticos. Nuevamente, muchísimas gracias y nos vemos mañana. Que estén muy bien.